Our next speaker is Dr. Harshul Tak. He's a highly trusted personality in the medical fraternity in Jaipur. He is a member ARC AOS, Chairman Scientific Committee Rajasthan Ophthalmological Society, Assistant Editor IJO Cataract Section, Executive Member IARSI, Governing Council Member of Indian Society of Cornea and Keratorefractive Surgeon. He is a recipient of Chikitsa Bhushan Award from Health Minister of Rajasthan in 2019, a finest surgeon and an excellent speaker. Capsulorhexis has a reputation of being the most difficult part of the surgery, and he will be showing us the art of making a flawless rhexis. Over to you, sir.
Thank you so much for a kind introduction. Am I audible?
Yeah, absolutely.
Okay. So at the outset, I'd like to thank Dr. Ramamurthy, Dr. Chitra ma'am for giving this wonderful opportunity and for this great initiative for education of postgraduate students. And can you see my screen, sir?
Yes, very well, very well.
Okay. So my regards to all the panelists who are there, from whom I learned a lot from all of you, Dr. Mahipal sir, Arup sir, and Partha sir, Dr. Rohit Prakash, everybody there. So I'll be speaking on the capsulorhexis, which we all know is the most crucial step towards a safe phacoemulsification. And of course, it is also one of the most difficult step of the phaco to master, especially for the beginners. And we all know that the correct size of and the well-centered capsulorhexis is essential for a good 360-degree overlap of the optic edge, because it prevents the optic tilt, optic decentration, and it gives a perfect effective lens position, which is very essential for the type of the premium IOLs which we all are using nowadays. So let's see how there are various ways to do the capsulorhexis. So this is the first which I'll be showing with the cystitome. So the bend of the cystitome, we must remember that it should not be completely 90 degree. It should be less than 90 degree so that we can easily lift the flap. So either once you cut horizontally and to radially 2 to 2.2 millimeters, either you can push this flap away from you or you can pull it towards you. So both the ways you can initiate the capsulorhexis. So I prefer to do it away from me so that the larger circle I complete away from me by the time I come in the subincisional area. So this is the cut which I gave in the center, which is very important to relax and release it so that we can easily. Now once you lift this flap and fold it over the anterior capsule, you just need to keep on pushing this flap and it should glide smoothly over the lens surface like this. And it's important that you keep on flattening it with the help of the OVD. And your incision is acting as a pivot, so you should try not to distort the wound much so that OVD doesn't come out. And see, I'm just gliding this flap smoothly over the lens surface, and I'm changing the direction as I'm proceeding forward. So you should be very careful when you come in the subincisional area, change the direction, and this is the way we complete the capsulorhexis. So it's now you can see that we have a good capsulorhexis here. Okay, so we have a good overlap of the optic, but in this case, you can see that the overlap of the capsulorhexis edge is more, which is not desirable, as the small capsulorhexis can lead to phimosis and can cause the hyperopic shift also. So it's important that you go ahead and use the micro scissors and use the micro forceps. So you need to be ambidextrous. I'm using my left hand here, going from the side port, and once I reach in that area, again I'm changing direction and enlarging the capsulorhexis so that we have a good overlap which is desirable at the end. So when you are using the forceps, the direction of the forceps, as you can see here, it guides the way in which the capsulorhexis should proceed. So it's by the shearing forces that we are making the capsulorhexis. It gives better control, especially in pediatric cataracts and the intumescent cataracts. So here again, I'm changing the direction and again re-grasping it to complete the capsulorhexis. So one should practice with all kind of instruments because they come handy in different situations. Now this is the pediatric cataract. We all know that the capsule is very elastic in pediatric cataracts, in pediatric cases. And also there is a positive vitreous pressure. So you should try to make a smaller capsulorhexis so that in the end you have an adequate size of capsulorhexis. So this is a case which was also having a microspirophakia. So I'm using the both the side ports to complete the capsulorhexis. Look at the direction of the capsulorhexis. So in these pediatric cases, capsulorhexis forceps is very helpful. So coming to the intumescent cataracts, we all know that there is an increased intracapsular pressure. So I always like to use sequential two-stage capsulorhexis. So it's like a dome. So if you need to walk, you can easily walk in the center of the dome. And for last 10, 12 years, I've been using this technique and used in thousands of cases, and it works very well. So stain the anterior capsule with trypan blue, and you can see these radial spokes. So these radial spokes are all liquefied cortical matter, and this is the intumescent cataract. So as soon as you give the neck, the liquefied material will try to come out. So you should always try to make a curvilinear cut, initial cut, and then put OVD, and then use a microcapsulorhexis forceps to make a very small opening in the center. So you can see here, I'm making a very small opening in the center. So once you have this small opening in the center, it's very safe to go ahead and debulk the capsular bag before you make an adequate size capsulorhexis. So I'm going with 27 gauge cannula. You can see the whole liquefied cortical matter is coming up. But remember that you don't have to put pressure on the edges of the capsulorhexis because the capsule is very fragile in these intumescent cataracts. So I go from the main port, debulk this area opposite to it, go from the side port and debulk now the area inferiorly. And I go from the other side port as well. So once you're debulked, you can see that the capsular bag, the pressure from the inside the capsular bag is reduced. So once you decrease down the pressure, now I can give a tangential cut here with the micro scissors and then make a capsulorhexis of adequate size to start the phaco. So in this way, you can easily manage the intumescent cataracts. Now see, there is no pressure in the capsular bag, so I'm creating a capsulorhexis of adequate size before starting the phaco. So that was about the intumescent cataract. So these are the Morginian cataracts. Here the issue is not of the increased pressure in the capsular bag, but you remember that the capsule is very fragile here, and there are a lot of anterior capsule plaques which are present. So you need to be very careful while completing the capsulorhexis. This is again the case which had lens-induced glaucoma. See again using the, now see in the, I'm making a very small rhexis here in the center. And once I make this rhexis, small rhexis in the center, I go ahead and debulk this capsular bag. See the whole liquefied cortical matter is coming up. I think you can easily appreciate the way it's debulking. I'm going from the other side port, debulking it, and then I can create capsulorhexis. So one technique which I think everyone should know, all the beginners, the capsulorhexis pullback technique. So let's see, I'm creating this capsulorhexis, but in this area, I feel that the capsulorhexis is going outwards. So you should stop at this moment only. Go ahead and put viscoelastic in front of the leading edge so that you flatten up the capsular flap. I'm putting the viscoelastic in this area. And then you try to hold the flap from the base and pull the forceps toward the center, keeping an eye on the leading edge, that this edge comes on the right path. So in this way, you can easily pull back the capsulorhexis, which is trying to go outwards. But the important thing is that you need to realize it earlier so that it has not gone up to zonules. So here I'm pulling it towards the center so that I can get it in the right path. So again, in this, there's one more case. I think I'll skip this case. So this capsulorhexis pullback technique is very important to know that the direction of the tear has to be centripetal towards the center. Again, there's a case which had a fibrotic plaque. So in this, the fibrotic plaque was in the center only. So I thought I'll definitely get away. But the important thing to note here is the direction of your forces. So again, I'm holding with this, see, it's trying to go in the periphery, but again, I'm holding it and pulling it towards the center so that I can get a steer in the right path. I try to initiate from the other side. Reach to this area. And then I realized that again, here there's a fibrotic band. So I thought, let's finish it from this. So again, I'm holding it from the base, from the base and pulling it centrally so that I can finish it up. Yeah. So I think a beginner should try to practice all the type of instruments and try to master each and everything, because anything can come handy in different type of cases. Thank you very much, Dr. Ramamurthy, for this opportunity.
Beautiful.
Very good, Dr. Harshul. That was amazing set of videos.
Thank you, ma'am. Thank you, ma'am.
Do you have an runaway rhexis? Because it's like beyond your talk. The runaway rhexis, when would you decide that you're not going to be doing in the bag phaco? Would you do a supracapsular or would you convert? What is your modus operandi?
See, I think the sign which Dr. Rohit Om Prakash has shown, flap motility sign, is very important. I think we should give a lot of credit to Dr. Rohit Om Prakash for publishing this sign. For years, we have been doing phaco in rhexis without realizing that this thing is there. But my technique, ma'am, is always remains same. I just reduce down few parameters. Otherwise, I love to do intact phaco only, unless and until there is a the flap stops being mobile and flap it loses, it stops fluttering. That time I realized that yes, it has gone. Otherwise, closed chamber technique is my favorite technique, and I never change it.
Yes, Mohan.
I think it's a brilliant talk by Harshul. I always love his videos. Really amazing videos.
Sir.
The most important thing as far as the capsulorhexis is concerned is maintain your chamber. A shallow chamber is the worst enemy for the capsulorhexis going away. So maintain your chamber always. Don't be what we call lazy to fill in the chamber, number one. Number two is, of course, the intumescent cataract. We have got different ways. There is a pressure in the posterior capsule also. That is why my puncturorhexis works very well. Nowadays, I am doing only femtorhexis for all these patients with the intumescent cataract. That's a different ball game, and take the questions later probably for that. But what Chitra asked was, suppose you have a toned rhexis or a runaway rhexis, I decide on the phaco on the density of the cataract. If the cataract is really a brown cataract, grade 4, grade 5, I would convert into an SICS or a ECC. Then rather go ahead and do. Because you can bring this nucleus up a little into the iris plane, the anterior chamber, but you will have white cornea the next day. Please understand this. So sometimes you can have the rexis going around, the tear going around into the equator, and it can have a nucleus drop as well. That is my message I would like to give all the people here.
I think that's an important point you made, Mohan. It depends on the grade of the cataract, also the comfort level of the surgeon.
Yeah.
Kind of wrap around, and that will be make things very messy. Any comments from you, Maipal? You might say that I'll do my capsulorhexis in 1 second using the femto, but remember the olden days and tell us something about it.
So what I'll wish to say is that, again, slightly elaborating on the point that Mohan was talking about, whenever there is a slight runoff or a runoff of the rexis, you have to try to retrieve the rest of the rexis. So it's not that if you have a runoff at a particular place, you just forget about it and then you don't try to get the other half done. So there is that other technique that Kamal describes, which is the inverted T, etc. So you should try to retain the maximum circumference of the rexis, even if there is a single runoff. The question is for you to judge as to your kind of expertise and the density of the cataract, and that is very, very important, which is there. I think Harshul made excellent points, and the other point that has been made is that often you should use the side port. If specifically you are using a micro forceps, that would be better that you also, even if you're doing a rexis, you can use the needle for the rexis from the side port. If you are using the main port, there is the chances, because most of us use methyl cellulose rather than Helon or equivalent. So there is a chance of the methyl cellulose seeping out. So under those circumstances, it may be a better idea always to use the smaller of the incision, that is the side port, and go ahead with that and use a micro forceps. That is specifically for the elastic capsules, and especially in children, as also in subluxated cataracts. And obviously what you were asking is correct, and as Mohan said that his procedure of choice as also my procedure of choice for an intumescent cataract, if the patient can afford, and normally I am able to convince them, then I will prefer to do a femtorexis in these particular cases. So that is all that I'll wish to say. Excellent presentation again, Harshul, and
thank you, sir.
Made certain excellent points. And trypan blue is something very, very important for all of us. Whenever in doubt, trypan blue. There is no harm if you put trypan blue, and even if you didn't need it. That is something very, very important that is there. The other thing I think which he did not, which also needs an elaboration, is that if you have brotic capsule,
yeah,
that you can do anything, and then you should one a curved one would be better than a straight one to make a circumferential cut, and then when the fibrosis is over, then again continue and try to make it into a.
Yes, Partha.
Yes, Harshul, excellent videos as usual,
sir.
And all your award-winning videos. Apart from these, your award-winning videos are there. So, points excellently made. One small thing, maybe for the beginners, I would like to suggest is a capsulorhexis marker, which can be placed on the cornea, and an imprint is there. So it definitely aids you to make as circular as rexis as possible, and especially for the youngsters. I think this is a very small tool, which is very inexpensive and yet can get you a very nice rexis. The other thing that, of course, helps us is the Varion. The Varion gives us an excellent rexis marking pattern. Of course, it's not possible for everyone to have a Varion. In Uday's presentation also, I did not notice a Varion being used, though I'm sure he uses a Varion, and this gives a great importance for the toric incisions as well as the toric markings. Because whenever we are doing a toric, and if we mark it with the pen, I mean the pen itself is at least the dot itself is at least approximately 1 to 2 degrees. So the chance of error is definitely there. However, having said this, and over the so many years that we have been using just the dots on the cornea and getting our alignments more or less okay, it is a very forgiving lens, even though there might have been a little bit of shift. Most of the dioptric error is corrected despite
That's
the
very
error.
good point you made, Partha. I've been using it for whenever the digital marking device is not available. I use a simple 5 millimeter circle. I mean, it's like the toe from my RK instruments. Just leave an imprint on the cornea, and it corresponds to about 5.5 millimeters on the lens surface. And when I go circumferentially around it, very often centered on the Purkinje image, you get a beautiful rexis. I wish it's more widely used. Comment, Srish? Quick comment.
Nice presentation, Dr. Harshul. Nice videos.
Thank you.
And a few points for the beginners. The size of these rexis can vary. For hard cataracts, you need a little larger rexis, and for patients with the PSF, you need a large rexis so that you can prevent capsular phimosis. And for PPC, it's a moderate-sized rexis. And for white cataracts, to begin, maybe you have a small rexis as shown by Dr. Harshul, and then you can enlarge it. If it is a moderately sized rexis, you can even go ahead and do a phaco, and then after implantation of the IOL, you can enlarge it. Double rexis can be done.
Srish, just very quickly, you have published about you are using a cannula and enlarging it. Would you just like to mention about it?
Yeah, I have a special technique called Canvac capsulorhexis, wherein it is for intumescent cataracts, intumescent white cataracts and intumescent immature cataracts, wherein I just make a small lick in the center and raise a flap, then use a cannula, 25 gauge flat tipped or a round tipped cannula, which is attached to a 5 cc syringe half filled with BSS, and I go to the side port and aspirate the excess viscous material or fluid cortex and catch hold of the capsular margin with the vacuum. I just pull the piston backwards and create a vacuum and hold the capsular margin, and with the vacuum itself I create a rexis. And when you are moving you're completing your rexis, if there is excess cortex, you need not come out. You just release the vacuum, and then with the same cannula, you aspirate the viscous or liquid cortex and continue with the rexis. The advantage of this technique is you need not come out of the anterior chamber. Most of the time, this rexis extension happens once the AC collapses. So you need not come out of the anterior chamber so that you can prevent rexis being extended towards the periphery. This is actually it is very useful in patients with white intumescent cataract with viscous cortex.
Two short comments from Arup and Rohit. We are already running short of time. Sorry.
I think, I just would like to emphasize a few points. Number one is the precise role of the OVD. You must choose your OVD according to the type of the cataract that you are dealing with. You can't have an intumescent cataract and then not have high viscosity OVDs in the theater and manage with HPMC. So that is not done. The second point was regarding the sizing of the rexis, Harshul. Wonderful surgery. Sir. But the primary rexis, if it is so small, sometimes a beginner, as he tries to hydrate the cortex and tries to remove it, remove it from the capsular bag, there may be a stretch of the circumference of the small opening, capsular opening, and that may tear. And the third point as regards sizing is, whenever the pupil is well dilated, fully dilated, and let's say highly magnification, if we try to make it parallel to the iris, to the pupillary margin, without any concern for the size of the rexis, you end up having a huge, capsular rexis, which you realize when you put the implant, the intraocular lens. So you can always have a visual estimate about the limbal diameter, whether it is 12 millimeters or 11 millimeters, and make sure that your rexis doesn't become more than 5 to 5.5 millimeters in diameter. These are the points I will emphasize.
Great. I think all Rohit, quick comment.
Yeah, for those of you who are using the capsulorhexis forceps, a very small tip, because some people do not really get into the capsulorhexis forceps because of the problems that they feel it is the chamber stability and it gets out of control. One factor which should always be borne in mind when you are not using a micro forceps is that the plane of your forceps should be, when you're moving it around, should be as close to the lens capsule as possible so that there is more control. That is the first thing, which I feel should be told to the youngsters that they should do. Second, if by any means, if they have an Argentinian flag sign or whatever it is, Dr. Harshul has already elucidated about flap motility sign. I would not like to go into detail. But one point which needs to be seen is that the safe techniques which should be employed should be such that your incision should not be parallel to the Argentinian flag sign, because that is something which you should try to avoid. And your, separational forces should not be perpendicular to the Argentinian flag sign, the axis of that. So that point should be borne in mind. And more separational forces should not be used whatsoever. And when you make small pieces and bring them into the anterior chamber and then emulsify, making it supracapsular emulsion.
I think all wonderful points. Thank you so much to all of you for bringing it up.